Today's topic is shock management, shock approach. It's a huge topic, and my goal for this lecture is to provide a fundamental understanding of what happens during shock and how to approach shock, because that's the most important thing about treating shock, is to know what kind of shock we're dealing with. And yeah, that's critical to the survival of the patient. So let me start with my outline for today's lecture. First, just a brief definition, it's one sentence. Then we'll get into the classical forms of shock, the signals of shock that you can look for as a doctor. Fourth, I will be talking about the approach to shock. I'll be specifically talking about two different approaches to shock, and we'll close with general ideas for treatment of shock. Okay, so the definition. Can you see this, or is my picture like over the, maybe if I go like this? Okay.
Everything is clear.
Okay, so shock is a life-threatening circulatory disorder that leads to tissue hypoxia and disturbance in microcirculation. So the key words here are hypoxia and microcirculation disturbance. So the classical forms of shock are distributive, cardiogenic, hypovolemic, and obstructive. And these are all descriptive words of what is causing the shock in the patient. So if a professor someday asks you guys, what are the forms of shock? You list four: distributive, cardiogenic, hypovolemic, and obstructive. And the distributive shock can have there are many various things that can cause distributive shock, but the three biggest ones, and probably most important one, is sepsis. That would be septic shock. Then I would say classically in kids with, for example, food allergies, there's the anaphylactic shock, for example, a peanut allergy or something like that. And then there's neurogenic shock, which is not as common as the other ones, but also very important. Okay, so these are just words and they'll make much more sense later. So let me get into the signals. So how do we recognize somebody that is in shock? Shock is it can be fatal, and the most important step to treating shock, as I said earlier, is recognizing shock. And we have three tools that are helpful that should make our ears perk up and be like, oh, is this patient in shock? I think I should be worried. And the easiest and the most approachable signal is the shock index. So what is the shock index? To determine the shock index, all we need is the heart rate of the patient and the systolic blood pressure. And if we build a fraction out of the heart rate and systolic blood pressure, and that is greater than 1. So if the heart rate, let's say, is 110, and the blood pressure, as here in my example, 100/70, 110 is greater than 100, and this means that the shock index is positive. So it doesn't mean this patient has to be in shock, but we should definitely, if somebody comes into the emergency department and has a pulse higher than the systolic blood pressure, we have to take a good look at this patient because they might be in shock. So that's the shock index. Once patients have been in the hospital and they're hooked up to all the monitors, and they're, for example, in the ICU and they have these displays, oftentimes you'll see this number, which is displayed right next to the blood pressure, and it says MAP, and it says mean arterial pressure. And I want to explain this a little bit more because for the first few years of my medical studies, I always thought, oh yeah, the mean arterial pressure is just the average of the blood pressure. But that's not true. So mean arterial pressure is the arterial pressure that is in the vasculature for one cardiac cycle. And I wrote this here, it is not the middle. So this diagram shows the arterial pressure during one cardiac cycle. And as you can see, most of the time, the values are closer to the diastolic blood pressure than to the systolic. The systolic blood pressure is just a peak for a very small portion of this cardiac cycle. So if we were to just establish the average and say, okay, they have a blood pressure of 120/80, and we think the middle is 100, then we would be giving them an untrue boost to their map. So their map is not as good as you think it might be. So the estimate formula for the mean arterial pressure is the diastolic pressure, which is down here in my example, 70, plus 1/3 of the systolic pressure minus the diastolic pressure. So the systolic pressure minus the diastolic pressure in this example is 60. 1/3 of that is 20. So 70 diastolic pressure plus 20, 90. That is the mean arterial pressure. I can't see the chat, so if there are any questions, Dr. Gould, please let me know.
Yeah, sure.
Okay, so and in medicine, the common definition of shock is when the mean arterial pressure dips below 65. But as always, there are exceptions. So lots of people that are in shock or a classic example of somebody in shock is septic shock, and it's a very old patient and they have pneumonia, they have heart failure, and they're just not in overall good shape. And as I mentioned, they can be chronic hypertensive patients, and these patients are used to a much higher mean arterial pressure. So if their normal blood pressure is 150/100, then they are going to be in shock much sooner at a much higher map than, for example, a young, healthy patient who has a normal daily blood pressure of about 120/80. So whenever the map is below 65, we're very worried, but do not forget that lots of older patients who have conditions such as chronic hypertension can be in shock with a map above 65. So far we have the shock index, which was heart rate through systolic blood pressure, and the mean arterial blood pressure. These are both blood pressure vital signals, vital signs signals that are easy to come by. And the third signal that we can see in the blood work is the lactate. And the lactate is a huge part of shock because if we remember our definition was tissue hypoxia and poor microcirculation. So hypoxia is the reason why we have lactate. Lactate is the biochemical sign of hypoperfusion and hypoxia of tissue. So as I mentioned, some patients will not be positive. They will not have a positive shock index, and they will have a map over 65. But if we look at their lactate will be high. So that means that somewhere there's hypoperfusion. And I wanted to tie back to biochemistry on where lactate comes from. So why do we produce lactate when we do not have oxygen? This goes back to one of the first things you learn in biochemistry or in chemistry is glycolysis. This is how our body produces ATP. This is what we need for energy. So during glycolysis, we produce ATP, as you can see here, and this requires NAD. In the process of glycolysis, NAD is converted to NADH. So what happens with this NADH? Because to do another round of glycolysis, we need this NADH to go back to NAD. This happens in the mitochondria, the powerhouse of the cell. So if oxygen is available, the electron transport chain, ETC, and oxidative phosphorylation in the mitochondria, they regenerate NAD from the NADH while producing additional ATP. This is a picture of or a diagram of the electron transport chain in the membranes of the mitochondria. So if we have oxygen, everything is good. We have glycolysis and we're using NAD, producing NADH, and then oxygen comes along and we regenerate the NAD. But if we do not have oxygen, what happens is the pyruvate, which is the endpoint of glycolysis, goes into lactate. And this step does not require oxygen. And here we regenerate the NADH to NAD, which we needed for glycolysis. This is what happens when we do not have oxygen. So if we do not have oxygen, more lactate is produced, and this is something that we can measure in blood work. So that is why lactate is a biochemical marker for hypoperfusion. The third signal. So I just summarized all of these on one slide for you guys to study better. Now moving on to the approach. So there are two ways to think about shock that I use when thinking about what's going on with this patient or understanding, okay, if this patient has this problem and now they're in shock, how did that happen? And how can I treat this? So the first, as you've already noticed, lots of shock has to do with math and formulas. So the first portion of my approach is going to be the shock formula. And the second approach is going to be a visual diagram of just following the blood and seeing where does it get stuck? Why is the blood not reaching my tissue, and why is my tissue being hyperperfused? So we're going to start with this formula, and I really think it's valuable to understand this formula and really review it and integrate it into all of your medical thinking, because it's so fundamental and it's so easy to have an overview over this topic once you understand this formula. And it's very simple. So without further ado, this formula. So shock is math. So the formula, these are all the abbreviations I've written on the left-hand side of the screen. So this map, which I've talked about earlier, which should be over 65, there are two factors that contribute to the mean arterial pressure in our vessels. First of all, there's the tightness of the vessel, which is the systemic vascular resistance. As we know, if we have a higher vascular resistance, a tighter vessel, the mean arterial pressure will be higher, which is good. And if we have lots of cardiac output, lots of blood flowing into the vessels, that is also good for the mean arterial pressure. So cardiac output, how much is flowing, and the tightness of the vessels this is flowing in determine our mean arterial pressure. So the cardiac output, lots of things go into cardiac output. First of all, there's the heart rate. So how fast is my heart beating and pushing blood into these vessels? The heart rate, and then there's stroke volume. So how much is one contraction of my heart pushing into the system? So that is heart rate and stroke volume. Stroke volume is affected by the preload, how full is my glass that I'm emptying into the system, preload, and contractility, how much strength, how much contractile strength is going into my expulsion of blood into the vasculature. So these are all heart rate, preload, contractility are all things that are affected by common pathologies such as myocardial infarction, chronic heart failure, cardiac tamponade, premature ventricular contractions, and tachyarrhythmia, and everything can be tied back into this formula. And a few weeks ago, for example, I gave a lecture on chronic heart failure, and that would fit into the contractility, but I'll show you this later. So this is the formula, and this is very important to understand if we have an issue, it is important to understand where it plays into the formula and how it affects the map. Okay, so as I mentioned earlier, there are 4 different kinds of shock. So if professor asks you, tell me about shock, you say there are 4 different kinds. First one is distributive. Distributive is a lot, it's distributive, and this is the systemic vascular resistance. So if we have a problem with systemic vascular resistance, we have distributive shock. All other types of shock are affecting cardiac output and thus affecting the map. So that was cardiogenic, hypovolemic, and obstructive. So the key difference between these and the clinical relevance of this structure in your head is that we can easily differentiate between somebody who's in distributive shock and somebody who's in a different kind of shock. So in all these kinds of shocks, cardiogenic, hypovolemic, and obstructive, cardiac output is negatively affected. Cardiac output is going to be low. So that means that systemic vascular resistance has to be high. So whenever cardiac output is low, systemic vascular resistance has to be high. This means that they will be cold. The patient will be cold. If systemic vascular resistance is high, the peripheral vasculature is very tight, which means the hands, the wrists, the lower arms, they are all going to be cold because we are centralizing our volume. For example, if we are hypovolemic, we have too little blood volume, and we want to keep it where our important organs are, our hearts, our lungs, kidneys. So it doesn't really matter if our arms are really strong. So the systemic vascular resistance goes up, no more blood goes to the hands, so our wrists and this area are cold. So if somebody is cold, we know that they have a problem with cardiac output. On the other hand, if they have a problem with systemic vascular resistance, that means they're having a hard time keeping the vessels tight and keeping them tight so that there's a lot of pressure and the fluid, the blood goes where it's supposed to go. So if we have a problem with systemic vascular resistance, usually we have a decreased vessel tone, as I wrote here. So the peripheral vasculature is going to be loose and relaxed. This means a lot of blood is going to fit through to the periphery, and our periphery will be warm. So our patient who is in shock is either going to be cold or warm. If they are warm, they have a problem with their vascular resistance, and they are in distributive shock. If they are cold, they have a problem with cardiac output, and they have one of these 3 shock forms. And this is very important to distinguish, because later, and I'm going to say this now, although it's part of treatment, this side is treated with pressors, and this side is not. And if anybody in cardiogenic, hypovolemic, or obstructive shock is given pressors, it is harmful to the patient. So it is very important to distinguish. And lots of people, they think, oh, shock pressors. We have to make these vessels tight and get this arterial pressure up, which can be a initial thinking, but in lots of cases, it's wrong. So that is why it's very important to distinguish between cold shock and warm shock and know which side of this formula you are on. So what are some problems we can have with, or how can we have different forms of shock? Trying to get this so you can see everything. Maybe like this. Perfect. Okay, so as I mentioned, there are different forms of distributive shock: neurogenic, anaphylactic, and septic. These all lead to decreased systemic vascular resistance. But now moving on to this side of the formula, so it is very, it's hard to, so I couldn't differentiate this into cardiogenic because cardiogenic is in multiple locations here. But when we go through these different factors that could tie into cardiac output, we can see what's going wrong. So the heart rate, how can the heart rate not be ideal? It can either be too high or too low. Preload, what can happen to preload? The preload can either be decreased or it can be obstructive. What can cause decreased preload? We can have decreased preload if, for example, we are dehydrated, we have diarrhea, or we are hemorrhaging and just losing blood. It can be obstructed in cases of, for example, pneumothorax or pericardial tamponade or pulmonary embolism. And we can have problems in contractility if we are having a myocardial infarct or chronic heart failure. So that was the formula, and I'll come back to it later again. But now let's think about this other approach, which is following the blood. So to follow the blood, the platform that lots of students in the US use has very good pictures. And so this is, again, I'm starting with distributive shock. So we're on the right side of the formula. This is affecting systemic vascular resistance. There are three forms of distributive shock: sepsis, anaphylactic, and neurogenic. So what happens in sepsis? In sepsis, there's bacteria in the blood, for example, and we have the body is overwhelmed with cytokines, and this causes leaky capillaries and extravasation of fluid. In anaphylactic shock, it's not cytokines, it's the histamine from the mast cells, which causes leaky capillaries and systemic vasodilation. And in neurogenic shock, we have a loss of sympathetic vascular tone, which means we have a predominant vagal tone or parasympathetic, which means that we have peripheral vasodilation and pooling of blood in the periphery. So if you look at this diagram, which is great, you can see we have multiple stations here. We have the right heart, we have the lungs, we have the left heart, and then we have the periphery, the arterioles and the venules. I see someone raise their hand. Okay. Very good explanation. Please explain the management of shock one by one. So I'll get into that later. Right now I'm still doing my approach. So yes, PCWP is post-capillary wedge pressure. So in the lungs, there is, we have the pulmonary arteries and the pulmonary veins. And between arteries and veins, we have the capillaries. And this is where oxygen transfer and CO2 transfer happens. So post-capillary wedge pressure is symbolic of the pressure after the lung capillaries And oftentimes it is just, you should just think about it of the pressure in the left atrium. So right here, once again, we have periphery. These are both the periphery. We have right heart, lungs, left heart. So in distributive shock, where's the problem? The problem is here. It's in the systemic vascular resistance, as in the formula that I showed you earlier. So the problem is we have decreased systemic vascular resistance. As a cause of this, the heart is pumping much more. So we have increased cardiac output. And because we have increased cardiac output, we have decreased pulmonary capillary wedge pressure, and we have decreased central venous pressure. SVR, systemic vascular resistance. So it's all about, okay, locating where our problem is in this form of shock and how this affects the stations of the blood beforehand and afterhand. Moving on to the next form of shock, cardiogenic shock. Cardiogenic shock, as I mentioned earlier when I had my slide with the different forms of shock, all these names for shock are descriptive. So cardiogenic shock, where's the problem? Cardio, it's in the heart, left heart. This means if the left heart is broken, the left heart is the function of the left ventricle is to pump blood into the periphery. So if we don't have this left ventricle working, we have decreased cardiac output. Keeping in mind our formula from earlier, if cardiac output goes up, systemic vascular resistance goes up to compensate. Because whenever the one of them goes down, the other goes up so that they can achieve a stable MAP, mean arterial pressure. So if cardio output is decreased, systemic vascular resistance is up. That means central venous pressure is up. And this is a backlog. So if the left heart isn't working correctly, then the fluid from the blood from the lungs is not going to be distributed as quickly as it needs to be, which means it is going to accumulate in the lungs. This means that the post-capillary wedge pressure is going to be increased, so that there's increased pressure in the left atrium because the left ventricle is failing. Examples of these are in patients that have a myocardial infarction. They have left ventricular ischemia. This decreases the contractility because there's less viable muscle that is working, and this decreases cardiac output. MI can oftentimes just lead to chronic heart failure. And as I mentioned in my lecture on chronic heart failure, there's different forms, but if you have reduced ejection fraction or a diastolic heart failure, which means the left ventricle can hold less blood volume, the heart will pump out less. There's decreased cardiac output. So those are two examples of cardiogenic shock. And myocardial infarction is a very common thing. So that's why shock is omnipresent in all topics of medicine. And you can see how relevant this topic is. And yeah, so let me continue with the next form of shock. So this one is, if I'm right, this one should be obstructive shock. I can't see the title, but yes, should be obstructive shock. So where's the problem in obstructive shock? The problem can be in a few different areas. I think the easiest to understand obstructive shock is to just imagine the pulmonary embolism, because the pulmonary embolism is an embolism in the pulmonary arteries, and it's just as if you were to block the blood right here and put a clog in the pulmonary artery, an obstruction. That's why it's called obstructive shock. So if there's an obstruction in the pulmonary arteries, right here, the blood is collecting before this obstruction because it can't pass the obstruction, which means central venous pressure will go up. So what is a clinical sign of increased central venous pressure? A clinical sign of increased central venous pressure is increased jugular venous pressure, which we can see if we ask the patients to look to the right or look to the left, and we look at their neck area, and we can see if their jugular veins are, the blood levels in the jugular veins are high above the clavicula. So if we have an obstruction in pulmonary arteries, that means less blood is going to get to the lungs, which means less blood is going to get to the left atrium, which means we have decreased pulmonary capillary wedge pressure. If left blood gets to the left atrium, less blood gets to the left ventricle. If less blood gets to the left ventricle, we have decreased cardiac output. Whenever cardiac output is decreased, systemic vascular resistance goes up to try to achieve a stable mean arterial blood pressure. So pulmonary embolism is the easiest example to understand obstructive shock, but there are other things that can cause obstructive shock. For example, cardiac tamponade. Cardiac tamponade can decrease the diastolic filling of the right heart, which in turn leads to decreased cardiac output. And tension pneumothorax can decrease venous return to the right heart due to increased intrathoracic pressure, which in turn leads to decreased cardiac output. So at the end of the day, we're always talking about the same things. We're always looking at cardiac output. We're always looking at where the blood is coming from and why it's not getting to the heart, or why the heart can't push it out into the periphery. So this was obstructive shock. And let's get to the next form, which is hypovolemic shock. So in hypovolemic shock, there's no cut in the flow. There's no obstruction. There's no heart ventricle that is too weak, and there's no capillaries that are leaky and everything is pooling in the periphery or just dissipating. So the distinctions that need to be made in hypovolemic shock is hypovolume of what? Is it hypovolume of blood, or is it hypovolume of water and just interstitial fluid? What is hypovolemic? So the distinctions that are made here are, is it a hemorrhage or a non-hemorrhagic hypovolemic shock? Hemorrhage is obvious. It can be induced by trauma or by upper GI bleeding from esophageal varices from chronic liver failure, or postpartum hemorrhage. So that is in a way easy to diagnose, because if a woman has just given birth to a child and she's postpartum and she's bleeding, we can see that. Or if somebody has trauma and they've lost half of their lower extremities, we can see the blood leaving the body. We know volume is being lost. They are hemorrhaging, they have had trauma, and they are losing volume, so they are going to be in hypovolemic shock. The not so obvious form of hypovolemic shock is, for example, somebody that has sustained burns on 20% of their body. They have increased, they call this insensible fluid loss, because in sense, I just remember this as you can't really make sense of it because you can't see it. It's just fluid evaporating from their skin. So these are patients that have had burns, or they are dehydrated, or they have lost lots of fluid from having diarrhea or for having gastroenteritis and vomiting. This is non-hemorrhagic hypovolemia. So the important thing about hypovolemic shock is that obviously if we draw blood and we are looking at the hemoglobin, the HB, this is a good indicator for if somebody is in hypovolemic shock, but it is oftentimes misleading. A good way to picture this is if somebody is losing large amounts of blood after recently sustained trauma, then they're losing an equal amount of red blood cells, or losing an equal amount of thrombocytes, of white blood cells, of plasma. And so the proportion of the hemoglobin to the rest of the blood is the same. So hemoglobin is always in, I think it's milligrams per deciliter, but it's always a fraction of something. And if we're losing part of the whole, the HB is not going to change that much. So in the beginning of hemorrhagic shock, the HB can be normal, but we shouldn't look at the HB after just taking a blood gas and say, oh, HB is normal, they're not in shock, they don't have hypovolemia. That's not true. So the HB can be normal at the beginning of hemorrhage. And in cases of, for example, burns, the HB can be totally unaffected, or it can even rise from dehydration and this serum loss and cause the red blood cells and everything in the blood to be more concentrated. So these can be, while HB, the hemoglobin, can be a good indicator for hypovolemic shock, it is very important to know that it can sometimes be misleading, and it is important to not only look at the labs, but to also look at the patient. The easiest example to remember this is with trauma. Somebody losing blood right now will still have a normal HB, but they will be in hypovolemic shock. Okay, so that was the concept of following the blood to think about the various forms of shock. This is a diagram that just shows you the difference of all these different stations in the system depending on the form of shock you are in. And right here I put the abbreviation central venous pressure, postcapillary wedge pressure, which is the pressure in the left atrium. And depending on the type of shock the patient is in, you can see how the other system should react in general. This is basically just a summary of all the slides we've already gone through for the individual shock forms. Okay, so now to treatment. And this is in the beginning when I was deciding if I should give this lecture, shock is a huge topic, and my main goal with this lecture is to show you that there is no simple formula to treating shock, because every form of shock is so different and requires different treatment. There's no page or step-by-step guideline that you can memorize or look at to treat somebody that is in shock. The most important thing about treating somebody who is in shock, who has a MAP of 50 and a positive shock index and lactate of 6, is recognizing, okay, why are they in shock? What kind of shock are they in? And then, as I will show you in a minute, it's giving the correct initial treatment, basically not giving the wrong initial treatment. And then the last step is treating the cause. But if we aren't able to recognize the form of shock they're in, we've already lost. So this is the most important step, recognizing what kind of shock the patient is in. And I can't stress this enough. So back to the formula, because this is when everything makes sense. We have cardiac output and systemic vascular resistance. If one goes up, the other goes down. If we have decreased cardiac output, our systemic vascular resistance goes up. So what does this mean, and what are the implications of this for treating somebody? If the cardiac output is decreased, systemic vascular resistance is up, the patient is in shock, we do not give pressors. We give them volume, because their problem is not that their systemic vascular resistance isn't good. Their problem is in cardiac output. So for example, if they are in trauma and they're hemorrhaging, it would be fatal to give them pressors, especially initially. What they need is volume. So when do we give pressors? And everybody's trying to give pressors in shock. We give pressors when we have a problem with systemic vascular resistance. How do we know if somebody has a problem with systemic vascular resistance? They're warm. So the most important thing you can do when you approach a patient who is not in good shape is you find out, are they warm or are they cold? If they are warm, you give pressors because they are in distributive shock and they have a systemic vascular resistance. Anything else, heart rate too high, too low, preload, too little volume, or obstructive shock or contractility issue after an MI or chronic heart failure, you do not need pressors. You have to think about other things. So give pressors when you have a problem over here with systemic vascular resistance. And if we, after this initial assessment, cold, warm, pressors, no pressors, then we have to treat the cause. So why are they in shock? Why do they have a problem with cardiac output? Or why do they have a problem with systemic vascular resistance? Let me start with the distributive shock and systemic vascular resistance. As I said, there are three forms: neurogenic, anaphylactic, and septic. The neurogenic is oftentimes spinal cord decompression is the treatment, because the tracts in the spinal cord have been harmed, and that's why we have a dysregulation of the sympathicus and the parasympathetic nervous system. So the treatment for this is very invasive. But for example, anaphylactic shock, which is a very common form of distributive shock, the treatment for this specific would be epinephrine, the IM epinephrine pen, EpiPens. Or if somebody is septic, the treatment is antibiotics. On the other side of the formula, if you have a problem with cardiac output, we have to see which part of cardiac output is not working. Do we have a heart rate that is too high or too low? Then we have to treat that with, for example, a defibrillation or antiarrhythmic medication or a revascularization. Do we have a problem with preload? If they have decreased volume, so if they have hypovolemic shock, why do they have it? Do they have diarrhea, dehydration, or are they hemorrhaging? Then we have to give IV fluids, lactate, Ringer lactate, or normal saline, or blood. If they have obstructive shock, if they have a pneumothorax, we have to dissolve the clot. If they have a pericardial tamponade, we have to do pericardiocentesis. If they have a pneumothorax, we have to put a chest tube and relieve the pressure from this pneumothorax. And if they have a pulmonary embolism, then we give heparin followed up with warfarin or the new oral anticoagulants. If they have a problem with contractility, most common thing is a myocardial infarction, then we have to send them to the revascularization site, the cath lab, or we give a clot buster. If they have chronic heart failure, we have to relieve them of volume and give them diuretics. And as you can see, this side is not a one-stop shop either. It's not just no pressors, because in some cases we need to give them fluids if they are in hypovolemic shock, but in some cases we have to give them diuretics if they have chronic heart failure. So it is, once again, the most important thing is finding out why this person is in shock. Where is their problem? Because each different contributing factor to cardiac output requires a different treatment, as you can see on this slide. So that concludes my approach to shock and how to think about shock and how to, most importantly, not make mistakes in the beginning. And how to recognize what you're dealing with, which is the most important thing in shock. And I don't know how much time I just spent, but I'm open to questions now. And